Okay, there we go. And I'm going to record it a second way on my cell phone.
All
So,
right.
what stories you got for me?
I figured the first one we'd start with today is one that stuck with me all these years. It happened about 15 years ago, I think. I'm estimating probably 12 to 15 years ago. And it's about a patient who I was seeing for the very first time, new patient to me. And of course, as you know, she was scheduled for a 15-minute visit, of course,
Mm-hmm.
right? Wasn't supposed to be, but reality hits. Somebody made a mistake. That's how they put her in. She walked in the door. This woman was in her mid 40s, very pleasant person, but she, if I could tell you, almost literally walked in with a wheelbarrow of 10 years worth of medical records.
Oh my God.
It wasn't a wheelbarrow, but it was a big, big stack, right? And I took a look and I see she's down for 15 minutes, and I know the power of family medicine. How do we manage this mistake in the system of timing? I should have had an hour and 15 minutes, but nonetheless, she sits down. I went through the usual greetings and hello and checking to make sure she didn't have any urgent or emergent problems, and then said to her, what we're trained to do is I, I need to see you for a more extensive visit than we have time for today. Why don't you leave your records? This was in the era of paper records still.
Hmm.
Why don't you leave your records with me? Give me time to go through them all, and let's schedule a 1 hour appointment in a week or so. She liked that. She was happy. During the intake, I realized that that gigantic stack of records was about a chronic pain that she had in her left arm and hand for 10 years. And then nobody was able to figure out what was wrong with her. She had been to every specialist in the world and still had the pain and was not asking for any pain medicine. So I knew it had nothing to do with seeking pain medicine. And she leaves. I start going through the records, and sure enough, she had been to an orthopedist, a neurologist, a neurosurgeon, a spine specialist, a hand specialist, name a specialist, a rheumatologist, everything to try and figure out why this chronic pain persisted. So she comes back after a week, and I tell her I went through all the records. Really could be summarized that every investigation that every specialist ordered, from MRI scans to electromyograms to nerve conduction studies to autoimmune markers, you name it. Everything was normal. Nothing was pointing to what the problem was. So I said to her, I have some ideas, and I took a thorough history, found out about her family history. There was no um, hint in her family tree about anything that would make sense causing this. Talked about what she does with her life, what kind of job was she uh, unable to do the work that she wanted to do? Did she have to adjust her life, and how much because of the pain? How did it impact her sleep? You know, all the things a good primary care doctor checks for. And there really wasn't much to point towards why would she have this. After I examined her, as with everybody else who had seen her, from the primary care perspective, there was nothing that was pointing towards her arm and hand. From each of the specialists, they could see in their histories and physical exams and laboratory and imaging studies, nothing turned up in the spots where they were looking: the hand, the wrist, the elbow, the arm, whatever. So I said to her, let me let me talk to some people who I would like to get some opinions from on her behalf, with people I knew who might shed some light on why this was happening. And I asked her again, come back and see me in another week. So what I did was, during that week, what any good primary care doctor does is I curbside opinioned everybody I could get a hold of that I respected, people I knew that could possibly be connected with why she might have this. And what it boiled down to at some point was me, as a primary care doctor, putting pieces together. The neurologist said, you should repeat her EMG study, look at her nerves. The orthopedist said, do an MRI of the spine. The spinal person said the same. Nobody was putting these modalities together, say, what about her, the person? So I had heard about a test that could be done that's rather uncommon. Do you know what an MRA is?
I do not.
It's an MRI to look at the anatomy of a certain part of the body, combined at the same time with an angiogram. So MRA stands for MR angiogram, magnetic resonance angiogram. You do both together and you overlay the information. And in this case, I wanted her to get that test done of her, what's called the axillary nerve complex up here in the upper arm where it joins the body. Is a big switching network of nerves here in the axilla, the underarm. And I wanted her to get an MRI and an angiogram of the blood vessels serving that area at the same time. My thinking was, maybe she's got an ischemia, a narrowing of the blood flow to that area that's triggering inflammation and symptoms in the nerves that are serving her arm and hand. So, like the good primary care doctor we all want to be, I looked at her insurance, and sure enough, she had a PPO insurance. And in order for her to get approval to get the test done, because it was a rare kind of test, she had to go to one of the only two people in the city of Los Angeles that did this test. That's how rare it's done. There's only two doctors, radiologists, who do this, and they both are at UCLA. So I applied all the paperwork and phone calls and whatever it took to get her insurance to say she's approved to get that done and it will be covered.
Right.
I get all the paperwork, I give it to her, I explain to her why we wanted to do this, and she takes it and thanks me very much and went off to schedule the test. This interaction with her, the first visit, that was now the third visit, occurred around the beginning of March of whatever year it was. That's a key element of the story for the show. Beginning of March. About 3 days after I gave her the paperwork to make the appointment, and it had to be with one of those two guys, either one at UCLA, she calls me up and she says, I called for the appointment for this test you want to get done, this MRA, and they told me the first available appointment they have to do that test at UCLA is in December. And this is March. And she said to me, at first I laughed. And then they said they weren't kidding. And then I got angry. And I said to them, you know, I've had this problem 10 years, but I can't believe you're telling me that there's an there's a 8-month wait to get an appointment to get this done. And of course, the clerk or whoever it was at UCLA said, that's the way it is. What do you want to do? And she got angry with them and they got angry with her and she slammed down the phone. Apparently, she told me. And now she's calling me and she's saying to me, fix this. And then she hung up on me. So I do my diligence and I call up one of the doctors at UCLA who I know does the test. And I get him on the phone and I tell him the same story I just told you. And he starts laughing. And I said, what's so funny? And he said to me, this happens here all the time, here being UCLA. He said, the other guy who does the test with him, the two of them, is on sabbatical. And when he went on sabbatical, UCLA took away all of my, this is the other radiologist telling me, all of my teaching duties and my research duties, and all I'm doing is my clinical duties. So they freed up a whole lot of time on my schedule to do things like this test and others. So I said, what's the problem then? He said, they never told the people who program the scheduling computer to change my schedule. And I said, well, oh, okay. What do we do about this? And he said, when can she come in? I said, she's willing to come in any day you have an opening. He said, oh, I got like 3 openings tomorrow. When do you want to do it? It's like, so call her back. She chuckles with me and says, thank you, thank you, thank you. And she goes and gets the test done in like 2 days. And sure enough, ischemia, narrowing of the blood vessel, key blood vessel serving this axillary nerve switching station under here. And that was triggering this problem. A relatively minor fix to get rid of that narrowing. Either I think she had a endarterectomy. You know, they opened it with a same thing they would do for a coronary artery, right? You get the blockage scraped clean, essentially.
Okay.
Solves her problem. 10 years.
Wow.
I wanted to tell you that story because it combined the kind of primary care vision of little pieces that everybody else was looking at, not putting the whole thing together, with navigating the broken American health system, with dealing with all of the social attached issues of getting her better.
Right. Well, that's a wonderful example of coordinating care, serving as an advocate for your patient. There's no way the patient could have gotten to that doctor or gotten to that
Correct.
issue because that
Absolutely true.
the wall was right in front of her and she's up close to it, but you were able to come in behind the door.
I go to doctors at UCLA for my own healthcare, and the same kind of stuff that happened with her happens to me as a patient, where I call up, I have a dermatologist who was there, and she was very popular. And she would tell me, okay, I need you to come back in 2 weeks and we're going to do another treatment on the thing on your scalp, something like that. And I say, okay. And then I'd go and call for an appointment and they'd say to me, oh, you know, her first opening is in 3 months. And I would say, no, she wanted me back. She asked for me to come back and said I had to be there in 2 weeks for the next treatment. But, you know, same kind of process where the
Right.
central scheduling efficiencies are, they lose the people in the whole story.
Right. Gotcha. Okay.
What do you
That's a good
think?
one. That's a good one.
10 years worth of records when we were on paper. Unbelievable.
Well, I think of this poor woman and the experience that she had. And just the, I've had those kind of things happen. And if you can find the back door, and, if it's a family practice office, I can generally find the back door. But if I just had this, so I've got sleep apnea. And and I put it off for the longest time. And I'm terrible with taking good care of myself. And so I finally got to this pulmonologist. He schedules an in-home test. The company that sends it to me, I open the box and I try to use the thing. I can't get it to sync with my phone, so you can't use it. So I call them up and they try to walk me through like I'm dumb, and of how to connect the phone and the device. The woman can't, it just doesn't work. So I send it back and they send me another one after a while. And I get this one to sync and I've sent it back. Well, I was calling today. This process started I think it was last November. And they still don't know. The company, I talked to the company and they've received the data, but it's never gotten to the doctor. So I called the doctor's office today. They've now got to call. I mean, that kind of stuff is legion. I mean, it's just,
Crazy.
yeah, crazy making.
It is
And
amazing.
hold on 1 minute. I am the gatekeeper for our cat. And if I don't, when she's ready to come in, the window is right in front of me here, and she will just be pounding on the window.
That is not the first time that happened with your cat. And I
That's right.
suspect your cat is pretty famous because it must happen when you're on calls with other people too.
That is true. That is true. Okay, so you got another story.
I got lots of stories.
Okay, I'm all ears.
All right. The next one I think would be great to tell you. It's just funny and could be included in the show. And it revolves around this whole idea of reducing medical errors. So I had this very lovely elderly couple that I was taking care of for years and years. And the time came for the husband to get his knee replaced. And he'd been putting it off and putting it off. He really needed it for 5 years and was hobbling around bone on bone. And he needed to get it done. Total knee replacement. His wife would come with him for every single appointment. No matter what it was for, she would be with him. And she came in the room with him. Very nice people. She'd sit in the corner and she would make sure when he told me answers to questions that it was accurate and fill in gaps and things like that. So time comes, his surgery is scheduled, and I was doing his pre-op clearance, medical clearance for his surgery the week before the surgery. And I do my history, and then I start my exam at the top, at his head, starting to work my way down. We get to the bottom half of the physical, and he takes his pants off, and and on the knee that was not going to be operated on, the good knee, she had written in indelible black marker, "Not this one." And I looked at it and I turned to her and she said, "I was a Navy nurse," like that. She was a pretty famous Navy nurse. She wrote a book about her experience in World War II.
Mm,
And she goes, "I was a Navy nurse." And she did what they do now
yeah.
routinely in the hospitals to make sure that a mistake doesn't happen. I thought that was such a funny anecdote that could be included on any show
Yeah,
that you're
yep.
doing about the foibles of American medicine.
Yeah, that's pretty sad when somebody loses a leg or an arm or whatever. That, oh yeah.
One more.
Yep, keep coming.
All right. Had a patient, um, again, came to me as a new patient, young guy. He was in his late 20s, healthy guy, except for one crazy problem. He kept getting abscesses in his chest wall, not chest wall, through his chest wall into his lung. They're called empyemas. So
Oh,
it's an abscess of the periphery of the lung. All right.
okay.
Very unusual to get these. Usually people who get them have immune deficiencies that allow for this to happen. He had no history of that. He had been checked for that, had no immune deficiencies as well as they could ascertain in his antibodies, nor in his cellular immunity that showed up in terms of white blood cells and bone marrow function and all of his blood markers. Everything was normal. But he kept getting these things. And he'd end up in the hospital because you got to open it and drain it. Patient has to recover. It could, if it doesn't go the right way at the beginning of the treatment, it could severe, he could die from this abscess. So he comes to me as a new patient, feeling fine. Um, Checked him out, everything, did the usual thorough workup of a new patient, history, physical, social history, family history. Nothing showed up. He was a student of dentistry. He was in dental school at USC Dental School. And again, this I'm going back like 20 years. Uh, might even be a little more than 20 years. But anyway, he becomes my patient, routine stuff, and then he gets one of these empyemas, and he gets admitted to the hospital, and he does well. Uh, Proper treatment, IV antibiotics. He gets better. He leaves the hospital. About a month later, he gets another one. And it's like, hmm, why is he getting these? There's no indication for why he's susceptible to them. He's not leading a life where he gets exposed to conditions that might predispose to getting infections, which could lead to an empyema, but we can't figure it out. So he goes into the hospital the second time, and like a really thorough primary care doctor, we go through a history that takes a couple of hours, thinking of every possible reason why he could be predisposed to this stuff from the environment around him. What is going on? Then we get an idea. And I'm saying we because it's me, the nurses, the people, the guys who cross cover me. We wanted to make sure this was not a manifestation of a very strange behavioral abnormality of his, of this, that something was going on in his head. Sure enough, so we concoct a story to kind of keep him busy when he's in the hospital. He was like with an IV pole, he would walk the floor to get fresh air and get out of the room and get out of the bed while he was still being treated. Get him out of the room, and I go over and inspect the stuff in his closet. Like, what did he bring with him to the hospital, knowing he was going to be there a week or so? And he's got this like gym bag, you know, small overnight bag of things that he brought with
Hmm.
him, a little bit of clothing and toothbrush and all his personal hygiene stuff. And then I find some syringes and vials. and cotton. And
Mm.
I'm saying, like, why did he bring that to the hospital? So when he comes back to the room, we sit down and start talking in front of with the nurse that was in charge of him that day, who knew him now well enough to know we were she was being a witness to what he was saying
Right.
in the answers. I thought of every question I could think of that would explain why he might have syringes in his overnight bag. Everything was no. I didn't say I had looked at it and found it yet, but the questions were all about crazy. What can you think of why a patient might have those things? Is it something he does for work, is school? What, he's in dental school. What does he need them for that? Everything was no, 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 no. And then we did the aha moment where I basically said, so why are these in your overnight bag? And he started crying. And he settled down and finally admitted that he hated dentistry. He didn't want to be a dentist. His parents were making him do it. And a manifestation of his rebellion against that, he was taking tap water, filling the syringe, and injecting through the cotton into his chest wall that water,
Wow.
which was leading to the empyemas. And it was his abnormal thinking
Yep.
about not wanting to be sitting in dental school classes to get him out of that. These episodes got him freedom from being exposed to that for, a week, 10 days, 2 weeks,
Right.
whenever he did it. I could see that discovery of that strange reason why he was getting these things being a good storyline kind of during an episode.
Absolutely. Absolutely. Can you tell me how you spell that word?
Empyema,
Yeah,
Empyema.
that's what I would have guessed.
Yeah, empyema. Like,
Yeah.
emphysema means the lung.
Yeah.
It's some derivation of that root, empyema, emphysema.
I
Crazy
figured it had
stuff.
I figured it had to be something. Um, uh,
Crazy stuff.
uh, yeah. Wow.
But the
Um,
thing there, I guess, if I was gonna talk to a writer who was doing a script, this wouldn't be something to make a show around. It would be something that was
oh, right.
happening during a show about another main story, and you have all these side stories going on in the same episode.
Right.
If I was talking to the writer, I would stress to them that the key to figuring out and getting him to break down and admit what he was doing was this ability to spend time knowing him in his life, asking every single question that you could possibly ask so he wouldn't have an excuse for why he had syringes in his bag in the closet having to do with some story he would concoct. And then at the end of that long questioning process, and you've exhausted every reason he could possibly have to have these things, he had to break down and tell the truth.
Right.
He like asking, like saying to him, "Is there any? Do you do any labs at dental school? Are you doing any kind of learning by working on cadavers or molds to make teeth or
Right.
whatever, where you have to use needles and syringes for any reason?" He doesn't know why I'm asking him that question, but the reason is I'm eliminating the possibilities for why he might be able to say, "Oh yeah, they're in my bag because we have to do this in our experimental psychology lab or something." I don't know what,
Mm.
you know
Hmm.
what I'm saying.
I do. I do. Good. Those are three keepers. And you're right. What I'm seeing with these So we've got a storyline that's flowing through the book. Um, but you know, the complexity of a primary care, a family physician's office is these things just sort of float in, or these people float in problems. And so the ability to um, slide those into the script, um, just to give everybody the idea of just how complex and intellectually challenging and interpersonally challenging it really is.
Oh, no question. The
Yep,
endless array of what's behind the surface, what's below the surface of
right.
so many challenges. I mean, you know the joke that there's several jokes that come to mind, but the one about um, you go to a party and the you're talking to somebody who's a specialist, and they hear you're a family doctor, and they say to you, "Oh, family doctor." That's where you learn more and more about less and less until you know everything about nothing. And then the retort, which is what the joke is we're taught to say back to the specialist, "Oh, specialist, uh, you're a specialist. You learn." Oh, I'm sorry, I got it backwards. I'm sorry. The
I was gonna
family doctor
say,
is you
yeah.
learn less and less about more and more until you know nothing about everything. And then the
Hmm.
retort is you're a specialist. You learn more and more about less and less until you know everything about nothing. It's a little
Yeah.
thing to put in a script at some point
Yeah.
that America, I think, would chuckle at. And
Yes.
then there's the other joke about a surgeon and a family doctor running for the elevator, and the door starts to close. And they both think, oh, how do I stop that door from closing? But I don't want to risk any part of my body that I'm rely on for my practice of medicine. So the family doc puts his hands in the way and tries to stop the door from closing, and the surgeon puts his head in the way.
That's good. I haven't heard that one before.
Write it down, write it down.
Yeah, yeah.
And then
No, no, I've got it recorded. I've got it
oh, that's
recorded.
right. And then the
Yeah, yeah.
last one, the last part of it, similar in a similar vein, there's a patient in an exam room in a hospital room, and the nurse comes running out of the room, and at the nurse's station there's a um, an internist, a specialist, and a surgeon. And she says, "Oh my God, you got to go in that room and see what's on the bed." So the surgeon runs in the room, comes out in 10 seconds and said, "I don't know why, but there's a squirrel on the bed." So she sends the specialist in, comes out in 10 seconds, says, "I don't know why, there's a squirrel on the bed." And she sends the internist in, and the internist is in there 10 minutes, 15 minutes, finally comes out in like 20 minutes. He says, "Well, there's a squirrel on the bed. Rule out chipmunk, rule out."
That's good. Yes, you've probably heard the one where a family physician, a psychiatrist, a surgeon, and a pathologist go on a duck hunting trip. Have you heard this one?
I think I heard you tell it at some
Okay.
point.
Yeah.
Yeah.
The surgeon blasts away when the duck comes and says to the path, go out there and get that duck and tell me if it's a duck. Anyway, so do you have another story?
Oh, I got lots of them. Probably a good one. Again, that kind of implicates or shows the challenge of primary care. Um, I had a patient who came to me because his wife was my patient. They had gotten married, and he came with a diagnosis of acute intermittent porphyria. You know what that is at all?
It's a blood disease, is it not?
Yeah,
Porphyria?
it's some kind of a I'm not an expert in it, but it's some kind of a defect in the metabolism of certain chemicals in the body that leads to intense episodic abdominal pain.
Oh,
Comes and goes.
okay.
And it's got a genetic component, and it's a disease that's very, very hard to prove a patient has or doesn't have. And it goes into this kind of, if I ruled out everything else, maybe that's what it is. At least back in the day when I was practicing. Maybe nowadays they have better testing to, conclusively know whether it is or isn't.
Mm.
But you always would make the diagnosis by ruling out everything else. And this guy comes in carrying this history, and his wife loved him dearly. They met and got married while I was still already taking care of her, and then inherited him as a patient. And he would have these episodes of excruciating abdominal pain, leading to him being admitted to the hospital, getting lots of pain meds, and spending, I don't know, a good better part of a week to 2 weeks in the hospital at a time.
Oh,
So after they're married about a year and he's had these episodes that happen, I would say he was getting them about monthly. She comes to me without him privately and says, Doc, I'm wondering what's going on here. He gets these episodes and then he gets zonked with medication, narcotics in the hospital stays. And I'm questioning, she's saying this to me, I'm questioning whether or not there's some psychological component here. And as soon as he heard that she was questioning him, the episode started to include seizures, where he would look like he had a grand mal seizure right in front of you. When he would be in the hospital with one of these episodes, all of a
yeah.
sudden now seizures were part of the whole clinical pattern. But I go over to see him at the hospital one day on one of the admissions, and I'm rounding on him, and the nurse says to me, Doc, you're going to think I'm crazy, but I got to tell you, he had a seizure, what we think was a seizure, and he says was a seizure. And I could swear that I glanced over at him on the bed when we were kind of getting some stuff ready, medicine ready during the seizure. I thought he opened one eye and looked at me and then closed it really fast, like he was faking it.
Right.
And she said, I'm not certain. I'm not accusing him of anything. I wanted you to know that I saw this.
Good nurse.
So with that information, with his wife's suspicion, what do? I bring them both in, have a heart-to-heart discussion with him in front of his wife about maybe there's some psychosomatic component to his somatopsychic condition, right? The difference, well, your background is social work, right?
Yep. Yep.
Somatopsychic. You have a real disease and it's affecting how you think and feel mentally.
Yep.
Psychosomatic, your thinking and mental activity is causing the condition. Both halves, always. So we have a long talk. We talk about what it could be, why is he getting the attacks? Why did the seizures start? On and on and on. And they leave, no resolution. His wife calls me on the phone and she says, what should I do if he has another attack? I said, here's what you're going to do. He has VA coverage as well as his private insurance through her, but he's a vet, so he has VA insurance. We
Right.
have a big, beautiful Veterans Administration hospital right here in Brentwood,
Mm-hmm.
a couple of miles from my office. And I said, Next time he has an attack, don't bring him to the hospital where I would be seeing him in the hospital and he'd get admitted. Bring him to the VA property. Go take him to the emergency room there. I know the woman she was my patient actually, who runs the whole psychiatric division of the VA here in LA. Long story short, the campus that it's on is divided by one of our major streets in the city called Wilshire Boulevard. North of that is all better behavioral health on the VA campus. South of that boulevard is all physical health. I said, take him over to the VA, take him to the emergency room, and if he has to be admitted, I'll get her and her team to see him and clue her in about what we're trying to figure out. Is he really getting acute intermittent porphyria attacks associated with seizures? Because apparently that can happen when you have that, in addition to the abdominal pain. Or is it psychosomatic? And that's the plan. So within a week or so, he gets another attack and she piles him in the car and she takes him over to the VA. As she's pulling into the parking lot at the VA, he opens one of his eyes in the middle of what he was seizing in the car. He opens one eye and he says to his wife, "Where are we?" Obviously, he was faking the seizure. And she says, "We're going to the VA emergency room." And he says to her, "Why? Why aren't you taking me to the hospital where Dr. Fromer can see me?" Which would have been Santa Monica Hospital. And she says, "Because we think you can get more help here." And he screams at her, "Stop the car." And the last she sees of him is his back as he runs away from the car to get away from the situation that he's now put in, where he's going to be admitted to the VA hospital, where he doesn't want to be, because they're going to put all kinds of psychiatric stuff on him there, right? They're going to have all kinds of behavioral health people see him. He disappeared for like 3 weeks. Couldn't find him.
Wow.
Didn't know if he was dead or alive. Missing persons, all this stuff. He just disappeared from the planet. And when he ran away from the car, he was fine. He wasn't limping or, holding his belly, which was
Mhm.
supposedly hating, and clearly wasn't seizing. 3 weeks later, I get a phone call from him. He went and he was staying and swore her to secrecy with his sister in Phoenix and wouldn't let her call and tell anybody, his wife or anybody, at me, that he was okay.
Wow.
And he calls me and he said he was faking it all along. They weren't real. The seizures weren't real. The pain episodes were made up. And it was all maladaptive psychiatric behavior.
Wow.
And we got him into therapy, treatment, and he got better. He didn't have acute intermittent AIP, acute intermittent porphyria. He had that diagnosis for like 15 years, and nobody could disprove it or prove it, and nobody ever went through this process of getting to the root of what was going on behaviorally. So big
That's
success.
fascinating. Yeah.
Yeah.
So, Steve Bierman,
Yeah, sure.
he would call it noetic medicine.
Right.
And yeah. Wow.
One more and then I gotta go.
Okay, one more.
Pick one. Do you know what trichotillomania is?
No, I do not.
It is a psychiatric disorder where a patient will twist and turn and pull on their hair until they pull it out.
Oh, I have heard of this. Yes.
I'm covering for my office on a Saturday, And what we do when we do that, back when I was in practice with a big group, the person working Saturdays would have an urgent care clinic all morning. We'd see maybe 20 people. So I'm in the office Saturday morning. Nurse comes out of exam room and says to me, the police are in there with a patient, Dr. So-and-so's patient. I didn't know her. And they brought her in because of they were called and how she was behaving. I go in the room and there is a woman sitting on the end of the table who had zero hair. She had pulled out all of her hair. At that
Wow.
point, I didn't know she pulled it out. She could have had some kind of autoimmune
Sure.
alopecia areata, whatever. No, alopecia universalis is what it's called if it's all gone. So take a history, blah, blah, blah. It was clear she was pulling it out very quickly. That's what happened if she pulled it all out. Why did the police get involved? They were called by witnesses who said she was being abusive and screaming at people in some public place and cursing at everybody. And I go in the room and the Santa Monica cop, nice guy, was sitting there watching her. I go in the room and she says hello. And then she says to me, in language I won't repeat on the recording about the cop, um, what she wanted to do to him in sexual terms and all kinds of, clearly they needed me to document that she needed
Sure.
psychiatric admission. She was a
Sure.
danger to herself and to other people. So we did that. That was a Saturday morning. They take her off to get her admitted to the psychiatric section of the local hospital. And I didn't hear anything further because when they go into that section, we didn't follow them medically.
Hmm.
Somebody else did at that time, and hospitalists and all that kind of stuff had already started to happen. And I didn't hear anything. About, I'd say 6 months later, I'm working another Saturday morning. I go in the room to see a patient, and there's a woman sitting on the table, and she looked familiar, but I couldn't place her in my mind. There was something familiar about her until I realized it was the same lady. And now she had a full head of hair and she was behaving like very normal. And she was there because she had dropped something on her foot or something and might have broken her toe. So that's why she came in on that Saturday. And I was like, I realized who she was and I said, wow, how you been? What happened in the last 6 months? And she proceeded to tell me a story that she got straightened out. She got psychiatric treatment. She got put on medicines at first, intensive psychotherapy, left the hospital, continued with intensive therapy and treatments. And now it's 6 months out. She doesn't pull her hair out anymore. She's under control. I think was ending up diagnosed with kind of manic depressive disorder, bipolar disorder, was stable and leading a normal life.
Wow. That's pretty phenomenal.
Think of
And
the things.
you could tell how well she was doing by just looking at
Yeah,
the hair on her head.
yeah, exactly. Think of the things you can do with makeup with an actress in the show, and having them look like they're totally bald and then having hair, having hair. So another story that came to mind.
That's great.
I have
Great.
more. A
I
never
suspect.
ending, never a bottomless pit of more stories of 25 years in practice.
Well, that's great. Let me process these. It will take me a while. And and we'll see. Um, it's an interesting thing. I'm going to stop the recording here.